Everybody, I would like to open the session on arrhythmia. My name is Piotr Suwalski. I would like to welcome my co-chair, Dr. Bisleri from Italy. And we'll start with the first presentation.
So the first presentation is entitled Stage Hybrid Approach for Treatment of Persistent Atrial Fibrillation, 1-year results of hybrid procedure versus catheter ablation by Dr. Chang in Korea.
Thank you, ladies and gentlemen. I'm Hyung-woo Chang from Samsung Medical Center, Seoul, Republic of Korea. We have nothing to disclose. In this study, a total of 117 patients with persistent atrial fibrillation were enrolled. And there are 54 patients in hybrid group and 63 patients in radiofrequency ablation only group. And hybrid procedure was performed from February 2012 to October 2013. And radiofrequency ablation was performed from October 2010 to March 2013. So in this study, the hybrid approach means that a thoracoscopic ablation followed by radiofrequency ablation 3 or 4 days later. So this table shows the baseline patient characteristics. And the proportion of patients who have experienced previous radiofrequency ablation was not significantly different between groups. And all other variables were also not significantly different. And this table shows some neurological characteristics and cardiac characteristics. The CHED score was also not significantly different between groups. So most of the time we began from the right side procedure. Firstly, pulmonary veins were isolated, and the ganglionated plexi were ablated, and then the superior and inferior lines were ablated. And sometimes we added superior vena cava ablation. And what we did first from in the left side was to divide the vein of Marshall, and pulmonary veins were isolated in the same way, and superior and inferior lines were ablated. And the ganglionated plexi on the left side was also ablated. And the final step was to ablate, to resect the left atrial auricle. Due to the time limitation, I will show you the last step of the thoracoscopic ablation, because many people were curious about how we do that. So we used an endostapler, and we tried to resect as much tissue as possible. And during the study period, we have never experienced any accident related to this procedure. So the patient was transferred to intensive care unit after operation, and we checked the bleeding from the chest tubes for the initial 2 hours without any anticoagulation, and the heparinization was started. And when necessary, we added intravenous amiodarone. And to prevent pericarditis, we added colchicine or naproxen with the proton pump inhibitors, and a 12-lead EKG was obtained. On the next day, the patient was transferred to general ward, and there we applied 24-hour wireless ECG monitoring, and the colchicine was maintained for 2 weeks even after discharge. And the heparinization was also maintained until EP study. And when the heart rate stayed above 8 beats per minute at rest, we added oral amiodarone. And chest tubes were removed as routine, and we checked echocardiography to evaluate the atrial activity. And the patients were generally transferred to EP cardiologist on the 3rd or 4th postoperative day. So after discharge, the patients came back to the outpatient clinic at 2 weeks, and at 3 months, and at 6 months, and after this, every 3 months. So we checked chest PA and ECG at 2 weeks and 3 months, and transesophageal echocardiography and 24-hour ECG was checked at 6 months. When the results of these 2 examinations were normal, we could discontinue amiodarone and warfarin, and instead we added aspirin here. So the left atrial auricle resection was performed in 51 patients, and superior line ablation was completed in 30 patients. Bilateral pulmonary isolation was performed in 54 patients. And we thought that the left atrial appendageal resection could be excluded in cases of very broad appendage or paroxysmal atrial fibrillation without stroke history, but this is not related to this study because all the patients in this study were persistent AFib patients. And when we could see the obvious appendageal contraction, we thought that the resection of appendage was not essential. And we did DC cardioversion in the operating room after finishing whole deablation procedure. And 44 out of 54 patients showed sinus conversion. And 15 patients needed additional cardioversion during hospital stay. And 7 patients were in atrial fibrillation at discharge. And 2 patients needed hematoma evacuation. And 4 patients showed sinus node dysfunction. 1 patient needed pacemaker insertion. And 3 patients suffered from substantial, not pater, but substantial pulmonary complication. So in the EP study, when the AP burden was 0, the procedure was to confirm the isolation lines and to ablate cable tricuspid isthmus. But when AP burden was not 0, 3D mapping and additional ablation was performed. So EP study was performed in all patients, but full-scale EP study was performed in 48 patients, and 17 patients were in atrial fibrillation when they entered the AP study room, and additional ablation was necessary in 11 patients. CTI ablation was performed in 44 patients, and mitral annulus ablation was performed in 3 patients. So most frequent site of additional ablation was here, the right side isolator ablator hinge point. So when you look at the freedom from AFib recurrence, you can see the clear difference between hybrid group and radiofrequency ablation group. And the 1-year freedom from AFib recurrence in hybrid group was 89% and 75% in radiofrequency ablation group. So we performed Cox regression analysis to identify the independent predictors of AFib recurrence. And we entered these variables, including hybrid procedure, and the result was this. The 4 variables were identified as independent predictors of AFib recurrence, and hybrid procedure was related to lower chance of AFib recurrence. So in conclusion, hybrid approach for persistent atrial fibrillation showed better 1-year results than radiofrequency ablation-only approach, and higher CHEST score, previous radiofrequency ablation, and diabetes were independent predictors of AFib recurrence. The thoracoscopy ablation only was not enough to make complete agent-sets. Thank you for your attention.
Thank you, Dr. Chang. Any questions from the floor? Dr. Wolf?
Randall Wolf from Indianapolis, Indiana. It's suspected in about 15% of patients or more with AFib that one of the major sites of the AFib is the left atrial appendage. So it's possible that you miss some of the AFib sites by not treating the atrial appendage in every case. And I was wondering why, if you saw some contraction of the appendage, you did not remove it. I'm also wondering why, whether there's a broad base or not, why you didn't remove it. In our experience, we remove all the appendages with the stapler.
Frankly speaking, it is related to the first initial learning curve. Actually, we are resecting all appendages now, but when we started this practice, this program, we were a little bit scared of resecting too large appendage, or some of the patients showed sinus conversion without DC cardioversion after finishing whole ablation procedure. So in such case, we thought that, frankly speaking, we were a little bit afraid of resecting those appendages. But now we are resecting whole appendages.
Well, it was a very nicely done study. I think it was very well presented.
Thank you.
Thank you.
Dr. Damiano?
Yeah, excellent study. Just had a question. First, did you look at how many of the patients, you said they all had persistent AFib, but how many had long-standing persistent as opposed to persistent? There's some data from the EP literature that, short duration of persistent AFib acts no different than paroxysmal in terms of its response to pulmonary vein isolation alone.
As far as I remember, because we were beginning this program, relatively hostile patients were transferred to us. So it means that the duration of atrial fibrillation was more than 10 years or sometimes 15 years. And as far as I remember, there was no patients with atrial fibrillation duration less than 1 year. So would this be the answer for your question?
Yeah, that's an excellent answer, and you really have excellent results in what's a tough group of patients. My last question is, when you reported your success at 1 year, you said freedom from AFib, but did you follow the guidelines of the consensus statement? And what was that did you, when you say freedom from AFib, was that freedom from all atrial arrhythmias, and did you define failure as just a 30-second episode?
Actually, we are checking 24-hour ECG at 6 months, 9 months, and 12 months. So, there are patients showing.
And how, I guess on those then, when you say freedom from AFib at 12 months, how did you define that? How much AFib was considered a failure?
How much AFib? At least we should not see any AFib episode in the 24-hour ECG. So, but we are seeing many frequent APCs, premature contractions. So we are using amiodarone to control, suppress the chance of recurrence. But I would say we are applying a relatively strict definition of AFib recurrence. So very slight, a small amount of AFib event or episodes were considered to be AFib recurrence.
Okay, thank you.
Okay, thank you very much. Thank you very much. And then we'll move